Yes. So, and, what we thought is to actually broaden our topic to pediatric surgical emergencies so that we can cover a larger area. So that, as students, you will benefit because, rather than know great detail of things of, like a small topic, we thought we will discuss the wider area. So, we thought we'll kind of introduce you to all the major common pediatric surgical emergencies and yeah, so these are the common things that we would see in pediatric surgical emergency casualty day. Abdominal pains, non-bilious vomiting in children, bilious vomiting in children. So that includes both children, neonates and older children. Then we would see acute scrotum, that is acute scrotal pain. Rarely we would see upper GI bleeding, hematemesis, or lower GI bleeding, hematochezia. Lower GI bleeding actually is more kind of a clinic problem, or a problem that you would see more often in the clinic than in the emergency room, but rarely you can have hematochezia or major lower GI bleeding as well. Then we would see like septic arthritis, swelling, swollen joints, and others are the inflammatory conditions, the lymphadenitis, cellulitis, and abscess formations. So that will basically cover, and of course trauma as well. So cover all the pediatric surgical emergencies, and we would deal with mostly, we thought we'll deal with a little bit of the acute abdominal pain, then maybe non-bilious vomiting, then bilious vomiting. Okay. So as in adult acute abdominal pain, we would try to narrow down our differential diagnosis whenever you have a patient. The idea is to get to the cause of it and then to treat it. So initially, clinically, you have to narrow down your differential diagnosis. So that can be done by asking the patient where it hurts most. So basically, you divide the abdomen into 4 quadrants. Majority of children will have different difficulty in to localizing the pain. Most of them will point to the center of the abdomen, but some older children especially will be able to say, okay, it hurts, say right lower, right upper, left upper, or epigastric, hypogastric, like that. And so again, you can assess the severity of the pain, and then associated symptoms also will help you differentiate the cause of the pain, the underlying factor like fever, vomiting, urinary symptoms, bowel not opening for days, like constipation, and then sometimes these will help. And also the chronology of events, the sequence of events, whether it is fever, vomiting, and then abdominal pain, or abdominal pain, then with the fever, vomiting, or the predominant symptom. And also the first symptom also is important, especially like say in differentiating dengue fever causing abdominal pain and that kind of thing, to appendicitis causing abdominal pain. So the first symptom would be fever, then vomiting, in that order. Then say abdominal, in appendicitis, it would be more abdominal pain, fever, vomiting, that sequence. Okay, so the order of events is also important, and then you would do your basic investigations, the full blood count, CRP, and UFR. So that will help to narrow down your thing further. But of course, the full blood count, you're looking at the white count, then you're looking at the platelet count, differential count, all that will help. So very important to do this full blood count, mainly to rule out other viral, like dengue fever, missing. We have, like, so people, we did not emphasize on this, some time back, and then there were few unwanted negative laparotomies or laparoscopies to do thinking that it's appendicitis, but turned out to be dengue hemorrhagic fever causing abdominal pain, and then symptoms similar to appendicitis. So generous, somebody who is not often dealing with children, especially, can fall into that trap. So a full blood count is a useful investigation, more to to sort of identify these dengue fever-like problems. And nowadays, even COVID associated these abdominal pains, MIS-C, and all that also. So full blood count is a useful investigation mainly in that event. And also in appendicitis, there will be a leukocytosis with neutrophil predominant leukocytosis, and platelet would be normal, or sometimes it's even higher. CRP is usually elevated in appendicitis, of course, not always. And the UFR, it's helpful, I mean, if there is a field full of pus cells in the thing, then that might lead you to say, okay, it's probably urine infection. But of course, a pelvic appendix or appendix sitting on the ureter can cause a few pus cells. So 5 to 10 kind of pus cells in a high power field is could be due to appendicitis as well as a UTI. Extra abdomen supine is useful. So you might sometimes see a fecal in appendicitis, but more actually to see whether there is, a lot of fecal loading, or whether there is intestinal obstruction associated with the problem, and that kind of situations. Ultrasound scan is also helpful in diagnosing, say a right-sided ureteric stone, or right renal colic, or sometimes cholecystitis, or biliary colics, maybe even pancreatitis, sometimes you might see. Picking up ultrasonically, appendix is not very accurate, particularly if it is done by a regular, using a regular ultrasound scan machine. They are not very specific, but of course, if it is a very obvious appendix, then it might tell you. But the false negatives and the false positives from ultrasound scan is so high that I don't think many pediatric surgeons would not be relying too much on the ultrasound scan. Probably the other investigation might be even more useful, but clinical examination, of course, is the eventual diagnosis, but these are helpful in your, if you're the primary care physician, pediatrician, or general practitioner, this will help you to narrow down your differential diagnosis, but the eventual person who does the operation eventually will have to make his diagnosis mainly depending on the clinical diagnosis. All these will help you. So it's the history and the clinical examination that is the cornerstone in the diagnosis of appendicitis. So supplementary investigation, so if in abdominal pain, sometimes if it is central, you suspect pancreatitis, you might have to do amylase. If you think it's cholecystitis, a HIDA scan might be useful. Sometimes, rarely, you might even have to do a CT abdomen. Now, recently, as recent as yesterday, we had a patient who was COVID positive. Now, was admitted to our ward, and then, so there was a doubt as to whether there is this, multi-system inflammatory syndrome associated with COVID in that patient, and then there was abdominal pain as well. So clinically it looked like appendicitis, but then in a patient with COVID, you don't want to do just a negative laparotomy to identify a normal appendix. So we eventually did a CT scan, and that also confirmed that our clinical suspicion. So eventually underwent appendicectomy yesterday. So the child is recovering now. So CT abdomen can be very useful in that kind of situation to identify the cause. And sometimes you might have to do endoscopies, rarely, upper GI endoscopy, and even laparotomy sometimes, you just do a kind of exploratory laparotomy. You know that there is a surgical abdomen, but you cannot sometimes identify the exact cause. So very rarely do you have to do that, but sometimes a laparotomy, exploratory laparotomy, maybe so that there is a bowel perforation or something like that, or whether there's a perforated viscera, then you might end up doing a laparotomy without knowing exactly where it is coming. But nowadays, we don't do a laparotomy to start off. We would put the laparoscope in, and then that will be more, so you can say diagnostic laparoscopy than laparotomy actually. So all these patients who are acutely ill needs resuscitation. So the management starts off even before you make a diagnosis by resuscitation. So we resuscitate babies who are in shock or who are dehydrated with fluid boluses. So I hope you are familiar with the fluid boluses in children. So a classical fluid bolus is a volume of 20 ml per kg. Sometimes you can start off, if you are particularly not very sure how much the dehydration is, you can give 10 ml per kg bolus fairly rapidly and then see the response. So response is assessed by measuring the capillary refill time, pulse volume, pulse rate, maybe even urine output. And then you repeat the bolus if it is inadequate. So, and then you get into maintenance fluids. So maintenance fluids, I think everybody must be aware. So that will be 4 ml per kg per hour, or commonly remembered as 100 ml per kg per day. But we usually write fluids in children per hour. We don't write for a day, fluids for a day in a child, because the things can change very rapidly. So you write, say, 60 ml per hour. So a child who is 10 kg will need 40 ml per hour. A child who is 15 kg will need 50 ml per hour according to this formula. So remember this formula. It's a very useful thing if you're working in a pediatric ward or pediatric surgical ward, because this is the way fluid is given to these children. And then again, the common management, pain relief is an essential part of treating any painful condition. So even before you make a diagnosis, you can always relieve the patient, relieve him of his agony and pain. So you start off with mild painkillers like in paracetamol, but in most abdominal pains due to peritonitis like appendicitis or other forms of peritonitis, mild analgesic is not sufficient. So you might have to go to narcotic analgesics early, like pethidine or morphine, because some of them won't tolerate oral things. Also, sometimes rectal diclofenac sodium suppositories would be useful. Sometimes you can use an antispasmodic for mild colics, like in acute gastroenteritis or things like that. Then also antibiotics, of course, then that's a little bit of a controversial issue. So we would generally, we do not like the first primary care physician, a pediatrician, to start antibiotics until we see the patient, because any inflammatory condition like peritonitis due to appendicitis can be masked by antibiotics. So once we examine and we make up our mind, okay, this patient, the moment we make a diagnosis of appendicitis, then we can start antibiotics. But if we are not sure whether it is like a gastroenteritis or whether it's like some other form of like say fecal loading or whatever, then if you just give antibiotics for all abdominal pains, then the ones that who needs surgical, intervention might be missed because the pain will disappear. Unlike analgesics, the antibiotics will mask the effect so that the signs of peritonism. So your clinical examination becomes difficult if antibiotics are started before you see the patient and make up your mind. Okay, but of course, if a child is septic due to peritonitis, that's a different matter altogether. Then that antibiotics becomes paramount. So if a child is septic and in shock, or then the antibiotics is a mainstay. But a child who is having a mild abdominal pain and where you haven't made a diagnosis, then needs you probably, it's a good idea to delay the antibiotics until the surgeons see them. Okay. So these are the common causes. So this you can see from this thing. So appendicitis is one, acute gastroenteritis. So you can get intestinal colics. I would say the commonest cause of abdominal pain that presents to our wards would be intestinal colics. So intestinal colics could be due to acute gastroenteritis, could be fecal loading causing, constipation causing fecal loading and then causing intestinal colics probably would be the commonest, because most of the acute gastroenteritis go to the medical wards because, they have vomiting, diarrhea, all that. And then appendicitis, mesenteric adenitis, urinary infections, and then gynecological ones like ovarian torsion, and the hepatic problems, the gallbladder issues, And of course, the pitfalls, because cholecystitis, biliary colics are rare in children. Gallstones is not as common as in adults. You might miss some of these cholecystitis, biliary colic, you might diagnose them wrongly as appendicitis or urinary infection. So you have to remember that cholecystitis and biliary colics do occur. It's a little commoner now than, say, 20 years ago. So that one, then Meckel's diverticulitis is rare, but you have to remember that's, that can cause appendicitis. Then acute pancreatitis is also possible, rare again. Primary peritonitis and testicular torsion. That's a very important one. So yes, as recently as last week, we had a patient, 14-year-old or 15-year-old boy, who went to the GP with abdominal pain, so lower abdominal pain and a little bit of backache also. And he was given coamoxiclav 600. He's a big made child who is about 75 kilograms. So he was given 625 milligrams of coamoxiclav twice a day and was asked to come back in 5 days, to assess, because he had low abdominal pain and some scrotal pain also, I think, at that time. But he didn't really examine, and also he didn't take the testicular pain very seriously, the GP. And so the child was on antibiotics for a day or two, and then because the pain was not getting better, came to a pediatrician, and then he was referred to us. And then by that time, the testes has undergone complete gangrene. So because it's the very important that low abdominal pain, backache, all those patients, it's very important that you examine the groin and the scrotum, because the incarcerated inguinal hernia in a small child also will present you with the parents will say it's abdominal pain because child is unable to pinpoint it. And early, in the early stages, very early stages, testicular torsion, the pain would be abdominal. Okay, because it's supplied by the T10, the dermatome. So it will be periumbilical pain to start off. So testicular torsion, incarcerated or strangulated hernias is an important. So it's essential that you examine the groin and the scrotum in all these patients with abdominal pain. Okay. So any questions on abdominal pain? I mean, this is that famous, it's a simile, like I did remember the causes of abdominal pain, like in a house. So, your ground floor is your abdominal causes. So all those intraperitoneal problems you remember as the ground floor problems. Then you always have to remember that there is upstairs. So that will be really the upstairs is really the chest we remember. So, lower pleural, say lower lobe pneumonias, pleural empyemas will cause it. Attic is more the the middle ear infections, otitis media, tonsillitis. All those can come to you as abdominal pain in small children, say infants, neonates with otitis media or bad tonsillitis can. The parents might come to you and say their child is crying because of abdominal pain. So remember that, look at the ear, middle ear, the throat, then listen to the chest and see whether there is a pneumonia. It could be a retroperitoneal problem like a pancreas, the ureteric colic, renal stones, girdle pain, prehepatic neuralgias, posthepatic neuralgias. Then the pelvis, the basement is the pelvis. So just way to remember the causes of abdominal pain. Before we get on to one of the causes, what are the pediatric causes of abdominal pain, a little bit detail. Any other questions? Anyone?
Sanjay?
Yeah, yes.
Sanjay, now one of your slides mentioned you do HIDA scan for polycystitis.
Yes.
Do you still do HIDA scan?
No, it's just, I think, old slide also, I think. So not in practice, but yeah, we do not, yes, we rely, yeah. One thing is we see biliary colics, but cholecystitis is rare, but the cholecystitis is extremely rare. Actually, only maybe a very small percentage of the gallstone itself is rare, but even out of the gallstones, maybe, I don't know how many percentage wise, but we see probably one a year maybe.
Okay.
But no, it's ultrasound. Yeah, it's based on ultrasound. I think that should be deleted probably. That was
Okay. Okay.
Yeah. So in adults practice also, I don't think it's done now at all. Huh?
No, no, HIDA and PIPIDA are no longer being done.
No longer done as well. Yeah. Yeah. Any other questions from students? So shall we get on to interception a little bit of detail?
Yes, sir.
Yeah. So so interception is invagination of a loop of bowel into the adjoining segment of bowel, usually commonly into the distal. So the proximal bowel invaginating into the distal bowel. The reverse interception is also described, but we do not see it often. So sometimes can happen intermittently in a patient with acute gastroenteritis where there is sort of very forceful peristalsis caused by the toxins. So can happen both ways, but so commonly for all purposes it's into the distal bowel, and most of the time this is idiopathic, or in that the classical presentation of a child who is being weaned. You see the interception around 6 months to 9 months, so it can be a little bit earlier. So commonest age range would be about 4 months to 9 months. And that is, we call it idiopathy because the exact reason is not known, but the common assumption is that when you introduce various foods, weaning foods, there will be, due to either the allergy or due to the proteins in it, the allergenic proteins in the food, the new proteins will cause a mucosal hyperplasia of the mucosa-associated lymphoid tissue in the distal ileum. And this sort of bulging of the mucosa because of this hypertrophy will act like a little polyp kind of thing, and a foreign body jutting into the gut, which will cause a lead point also. But because it's not like the usual pathological lead points, which is either duplication cyst or like a lymphoma causing a wall hypertrophy, or inverted Meckel's diverticulum, or some other tumor. Inoxanular in purpura sometimes again can cause submucosal edema. Sometimes Pew-Schegger syndromes, again small bowel polyps. So these can act like a pathological lead point also. Will cause about 10% depending on the series, depending on the age. So the common age group predominantly are all idiopathic. Anybody under about 9 months, almost nearly 100% of them don't have a lead point. Maybe 1 or 2% do have, but the older children, anybody over 1 year, we would always be looking at them with a suspicion. So quite a number of them have pathological lead points. And so this is what happens. A pathological lead point is like a little polyp or a hyperplasia of the lymphoid tissue, like in a lymphoma or inoxanular in purpura. And then the gut interprets it like a foreign body in the lumen. And then that's being pushed out by the gut, and then it drags the bowel to which it is attached, and then it's carried forward. Okay, so that's what is interception is. And so that's what happens. It gets dragged in. And again, this is the ileocecal junction going in. So the real problem of the interception is more than the gut going in, the attached mesentery also gets dragged into the bowel. So the problem of that is this mesentery has the blood supply to the interceptum, thereby, so, and also it's very bulky, so it gets compressed between these two walls, and there is high ischemia, or initially, of course, the veins get compressed, and then there will be even further edema, and then it swells up even further, and eventually there is occlusion of the arteries, and then ischemia, and eventually necrosis and gangrene. Okay, so that is the problem. The mesentery is going and getting stuck inside. And so fortunately, nowadays you can diagnose interceptions by doing ultrasound scans. So you would see target sign like that, like, so this is the bowel inside, the outside bowel, and the edema in between. So you would see it like a target, then you can, pseudo kidney appearance also they say is one of the features. And then that helps you in diagnosis of the condition. Of course, the clinical presentation is the classic, the child screaming episodes lasting for a few minutes, and then in between a few seconds sometimes, and in between the patient is quite well. The child is usually a very healthy, otherwise well child who is commonly in the, around 6 months of age. So those patients are very well and suddenly develop colic abdominal pain. And then during crying episode, it's, you can't console the patient. So unconsolable crying, and then, drawing the legs up, and suddenly the children can become really pale and deathly appearance also during an episode. So that's classic. And rarely do you see red currant jelly in the early stages. So most of the time nowadays with those colics, the people end up undergoing ultrasound scan is referred early. So nowadays we see maybe less than 10% have bleeding per rectum. So red currant jelly, that used to be a cardinal symptom when we were trainees or medical students, we would have seen a lot of patients, little babies coming to us with red currant jelly. But for the last, maybe 10 years, we would have seen only a handful of patients coming with red currant jelly, because they all come to us now early. So that reduction is easier. So this is what you would see. This is not a common occurrence because we do not need to operate these children commonly. This is the intraoperative appearance of, that's the distal bowel. This is the bowel that has gone in, so that you can see like a little, like as if a python has swallowed some animal. The disc bowel has gone in, and like a little bulge here. So that's what you would see if you operate these patients. But we nowadays we very rarely operate on them. So majority of them are managed by what is called non-operative reduction. So we use on all our patients what we call hydrostatic reduction. That is large diameter, like a 20 gauge, 20 French or 18 French Foley catheter is inserted into the rectum, and then the balloon is inflated inside the rectum, and then you pull it down to snugly fit the balloon. So usually you have to inject about 20 ml of saline or air into the balloon, and then so that will kind of inflate, and then you gently pull it down so that it sits on the anal sphincters tightly, and then you start sending a normal saline through this tube. You connect this to a saline drip set, and then hang the saline bottle about 100 centimeters at a level which is about 100 centimeters higher than the table. You see it. So the pressure inside the fluid column is about 100 centimeters water. So that will go into the colon, and then we'll go from sigmoid into the ascending, and then eventually we'll meet the interseptum at either transverse colon or descending colon, and then because of the pressure, it will squeeze the contents backwards. Okay, and then eventually will reduce. So you can either monitor this by doing serial ultrasounds on table, intraoperative ultrasonography. So we'll show you that the lump reduced. That's what we use commonly at LRH. But you can put some contrast material, not barium, but water-soluble intravenous contrast like Omnipec into the saline, and then you can watch the reduction, using fluoroscopy, also very intermittent screening. And then once the contrast enters the small bowel, then you know that this thing is reduced completely. Okay. But in late presentation, so if there is a pathological lead point and it doesn't reduce completely, then you might have to, you try it a couple of times, twice or thrice maximum. And then if it's not reducing, then you will put the laparoscope in and confirm that it's not reduced. And then you can either deliver it through the umbilical port and reduce it, or sometimes you can do a simultaneous, while doing the laparoscopy, you can again put saline in and then help the reduction with the laparoscopy, with the instrument as well. But if it is not, and sometimes if it's huge and very tight, you might find it difficult, but you can then deliver the interception through the umbilical port, make it a little bigger and deliver it, and then reduce it open also, but without making a larger incision. Okay, so that's all about interception. Any questions? Any students have any questions? We can. Have you all seen hydrostatic reductions? I don't know whether most of the patients are transferred from Ragam as well, those with interception, but maybe some of them are using the method. So have you seen hydrostatic reduction of interception during your pediatric appointments or surgical appointments? But that's a common occurrence. At least we have 1 or 2 a day. So when you come here, if you happen to be on a classic, casualty day, admissions day, you will be able to watch.
Sanjay,
yeah.
Just to clarify, now hydrostatic reduction is the modality of choice nowadays to treat interception. But if there is red currant jelly or continuous pain, is it safe to sort of do hydrostatic reduction?
Yeah, so when we were actually nowadays it's rare for the red currant jelly because it usually takes a couple, maybe a day or so of interception to come. But red currant jelly itself is not a contraindication. But if you feel that the patient is septic and in septic shock, or there is obvious perforation before the patient procedure, if you see free gas or child in septic shock, then maybe a contraindication. But the common thing when we were registrars or senior registrars, say 20 years ago, then we would do, commonly they come, most of them had red currant jelly, and we did reduce them. And so that's, red currant jelly by itself is not a contraindication. Yes.
Okay, thank you. Other thing is, now when we were registrars, we used to run this saline through rectal tube about 1 meter up, and we didn't have ultrasound guidance or fluoroscopic guidance. We go by the rate. So
also,
is it still in practice?
Because we have ultrasound, and this procedure is nowadays done in the theater at LRX, because in another hospital, during a procedure, I think the operator has used a little higher pressure, and then it perforated and caused a problem in one of the children in a different hospital, of course. But after that, everybody got a bit worried, and then now the procedure is done always in the theater with everybody around. So the theater has an ultrasound machine, and all our SHOs, the people are now trained to observe, do the ultrasound. So they use the ultrasonography machine. But at the same time, we have told them also to, stick a plaster on the side of the bottle, and then, every minute you mark the level, and that also helps to confirm. So initially when the colon, the distal to the obstruction is being filled with the saline, there will be rapid infusion. So it will be, very fast filling. And then suddenly when the column of water saline encounters the interception, then the rate is reduced, almost static for a few minutes. And then once it is completely reduced, also if the saline enters the ileocecal junction and into the ileum rapidly, then again it will go fast. But the drawback is sometimes if there is leaking, sometimes there will be fast rate even at the time of interception also. So you have to be wary that if there is no leak, the rate is a very good guide. But if there is leaking, a lot of leaking around the anus, then it's not a very good thing. But it's useful. But not, so if you do not have ultrasound at hand, yes, it still can be done by looking at the rate also.
Other thing, now those days, today I agree that the target sign or the ultrasound is the diagnostic tool of choice. But with sort of radiology also, the plain X-ray abdomen, is it still good?
Sometimes in the older child, when we think that the ultrasonography findings are not particularly in that situation, when some of these older children, say we get sometimes referred as a 4-year-old who has not opened bowel for about a week, coming to us with, intermittent colicky pain. And they sometimes come with ultrasound saying intussusception. And when we feel fecal masses, and we just want to confirm that it is not intussusception. When you do X-ray, and if you can see, formed feces right up to the cecum, then you can almost rule out ileocolic intussusception. If at all, it will be ileal, then not, because the cecum, if you can see, the fecal matter, that kind of, so mostly to rule out than to confirm a diagnosis. But so if you do a plain film, and if you see like a, like a sausage, like this intussusceptum also will be radio opaque, but that will be like a, almost like a solid organ, like a liver kind of, where the right iliac fossa will be fairly gasless and almost homogeneous, not the appearance of that moth-eaten, like a feces kind of appearance. So in that situation, you can confirm it also. But the brain X-ray is done either to look at that and see how the proximal bowel is dilated, like in a small intestinal obstruction, and very little gas distally, because all of that will be empty, as opposed to some other cause like intestinal colic due to gastroenteritis or fecal loading will have a lot of feces, a lot of gas in the large bowel also. Whereas the intussusception, the distal large bowel will be empty and free of stools. I mean, there may be a little bit of it, but most of the feces will be evacuated, because now whenever there is an intussusception, there will be forceful peristalsis of the gut. So that will empty the distal bowel after a while. So that will have maybe a little bit of feces, but certainly not much to show in X-ray. So if you feel that, that is also useful, yes.
Yeah. One final thing to clarify, sort of, you said sort of you reduce intussusception in the theater, but it is not under anesthesia, I suppose.
Yes, mostly under sedation.
Or is it under anesthesia?
Some units,
right.
Units. So if the child is very restless, and if they are worried to give intravenous morphine, then they might hold the mask and sedate the child with some gases as well. But not, we would advise the people to do it only with usually some intravenous analgesics, yeah. But
once it is reduced, how long you will observe this patient in the ward, because this hydrostatic reduction,
so if we are,
is it associated with recurrent intussusception?
Yes, yeah. So recurrence is particularly common if there is a pathological lead point, but the majority of them do not recur. Only about so the common idiopathic, or the the infants who come with hydrostatic reduction, the recurrence is not as common. But if you do ultrasounds in all of them, sometimes the ultrasonographer might say there is persistent intussusception, because there is a lot of edema of that ileocecal valve area. The intussusceptum becomes so swollen that even a post-op ultrasound might, post-procedure, even when it is reduced, they might have quite a high false positive rate of persistent intussusception. So what we normally do is, so if we feel that we saw a lot of saline entering the ileum freely on the ultrasound, and the patient, the on table feeding, or during the procedure, if we felt that it got reduced, we would start feeding as soon as the child comes out of sedation. Then we will start breastfeeding if he's on breast milk, or some feeds if the child is not having colics, and then the child's open bowels, and then is quite happy. But if you keep them fasting for long, and the child cries then for milk or because of hunger, and then you might interpret that as he's getting colics again, he's crying again, and then you send it for a ultrasound, and the ultrasonographer says, if there falls, say particularly if it's an inexperienced sonographer, then in the middle of the night, that would be normally a MO is doing it, and then they might say, there is persistence of the intussusception, and then you might wrongly diagnose it. But the thing that we do normally is we clinically assess them how they are, and you can feed the lump as before. So then we would feed them, and if they open bowel normally, and then the child is not getting colics, that would be the best way to probably observe them. But so usually they are in the ward so they come the day of the, the intussusception that's reduced. The next morning, they are fed, or in the night they are fed after a couple of hours. And then if they are okay, they are discharged home if they have a normal motion. But so we rarely do ultrasounds. We do not really often do ultrasonogram to confirm the reduction. That's done more clinically, and then you feed them and see. So yeah. So there is no set time to observe, but the pitfall is that they might cry because of hunger, and then that can be missed. So I think it's a good idea to, if you feel that the thing got reduced, you can always give them a breastfeed and see if the intussusception persists, then they would be crying again. And then of course there won't be opening of bowel, and you will see the same process. In that situation, then you would do ultrasound scan, and then that might confirm, and then you might redo the reduction again. So hydrostatic reductions, particularly in a child under 1 year, you can repeat it once or twice, and then so altogether about 3 times. And then so usually with about a half an hour interval between. And so if it is, so if particularly if you feel that it's not reduced immediately, then it's a good idea to go again and reduce it without waiting for too long, because then the intussusceptum, it's got partially reduced, and so then it becomes easier to reduce it completely the next time. If you wait for a long time, again that could have got progressed again. So yeah.
Thank you.
Any other?
Hello, sir.
Yeah.
If this intussusception is due to a pathological lead point,
yes,
the management of the pathological lead point is also.
Yes, very true. Yeah. So that needs to be attended to. So usually they come back with repeated intussusceptions or failed reduction also. In that case, so you would reduce intussusception after laparotomy or laparoscopically, and then if you feel that there is a polyp, because now most of these intussusceptums are so edematous that after reduction you would feel that there is a lump inside. So in a normal child who is that classical age range 6 to 9 months, we would rarely be opening them up. But even at laparotomy, you might feel that there is a lump at the ileocecal junction that might feel like a polyp or something. Very unlikely to be a pathological lead point in the 6-month-old. But if it is an older child, and if you can feel a definite polyp or a Meckel's diverticulum or duplication cyst, recently we had a duplication cyst of the ileocecal junction causing an intussusception. So that kind of situation, yes, we have to resect that segment and do end-to-end assessment. These ones are usually ileocolic. So the point intussusceptum, the apex is the ileum, not the ileocecal junction. But the classical idiopathic intussusception is ileocolic intussusception, where the lead point is very close to the ileocecal junction. So that will also help in differentiating the thing. So yeah, so the lead point has to be excised for you to prevent recurrence. Yes, very good. Yeah.
Thank you, sir.
Anything else? Shall we get on to bilious vomiting then?
Yes, sir. Yes, we'll get on to sir.
Yeah, okay. So again, a very significant finding, bilious vomiting, simply because if you see bilious vomiting, until you prove otherwise, you assume that there is intestinal obstruction, pathological. So unlike, say, non-bilious vomiting, majority of it is like a physiological reflux that you see in the infant or the neonate. But so non-bilious vomiting, large proportion is physiological, not pathological. But some of the non-bilious vomiting is pathological. So say hypertrophic pyloric stenosis is a pathological distinct entity, or sometimes pathological gastroesophageal reflux also can be there. But pyloric atresia, very rare condition, like other bowel atresias, pyloric atresia, like a membrane across the pylorus can cause non-bilious vomiting. Of course, that will be in the newborn. Immediately after birth, the child will be vomiting the milk. So apart from that, the bilious vomiting, that is that obstruction distal to the opening of the bile duct, is pathological always. Okay. So if the bilious vomiting is associated with the distended abdomen, then you know that the obstruction is in the distal small bowel or large bowel. But if the abdominal distension is not a feature, or if the abdomen is scaphoid but the child is vomiting bile, then you know that the obstruction is close to the bile duct. So like in the jejunum or distal duodenum, that area. Okay, so that's an important differentiating feature. So the most valuable, apart from your history, which is all these how the onset and the progression, the next important piece of solving this puzzle is a plain X-ray abdomen or X-ray abdomen, AP, and always a supine film. Simply because we do not want all these neonates and infants who are hypervolemic because of vomiting and in shock most of the time to be kept erect. So because of that, and also the supine film will give you a lot more features, you know, to the location of the obstruction, number of bowel loops that are there proximal to it, and the distance, you know, the appearance of the distal bowel. All that information can be obtained from a supine film as opposed to erect film. Erect film will only show you that there are some fluid levels, and you will not be able to say, okay, is this small bowel, large bowel, duodenum, stomach? All that is a bit more difficult. So erect X-ray is almost contraindicated in a child, especially in a child who is ill enough to be having obstruction, peritonitis, or those patients can sometimes collapse and die in the radiology room if you ask them to do a erect film, because the erect film is useless unless you keep the patient erect for at least about 10-20 minutes. And by that time, they would have suffered irreversible brain damage because of the hypovolemia and then the loss of blood supply to the head. So yeah, so you don't ask them to for erect X-ray. So it's always a supine one. But if you are looking for a perforation, and if you want to see free gas, so that's very easy. So what you do is you turn them to the side, the liver side up. So that's called the left lateral decubitus. So the liver side, right side is up, and your gases will collect under the lateral abdominal wall, and between the liver and the abdominal wall, you will see a little pocket of gas. And of course, you have to ask the radiologist to do the left lateral decubitus. So you're still looking at it like an AP X-ray, but taken laterally because you're, you know, so the beam is going horizontally across the abdomen. So abdomen will be seen like an AP view, but the AP view with the liver up, or the left side, right side up, left lateral decubitus. Okay. And so supplementary investigations would be upper GI contrast series or contrast enema. So the causes, the common causes of intestinal obstruction or bilious vomiting in a child, either newborn or neonate, would be a malrotation or midgut malrotation valvulus. Then that's about 1 in 3,000 to 5,000 births. Duodenal atresia, more or less the same incidence, 1 in 5,000. Intestinal atresia, so either jejunal or ileal atresias, also have the same incidence. Meconium ileus, probably about a little bit more rare, especially rarer in our situation. Meconium ileus is a condition associated with cystic fibrosis, so rare in our population, maybe 1 in 10,000 or 20,000. So, but it's commoner in the West because cystic fibrosis gene is commoner in that population. So then you can have adhesive obstructions, which is usually following a laparotomy or can be following meconium's peritonitis or meconium cyst. Then intestinal bands, which are congenital, like a Meckel's diverticulum band or some other congenital bands. And also even things like Hirschsprung's disease or meconium plug syndrome can present to you like intestinal obstruction. If there is, say, total colonic Hirschsprung's or any classical Hirschsprung's, all can present like intestinal obstruction. Of course, they will be very distal obstruction with a lot of abdominal distension. Okay, so these are the causes, and So midgut, just to get on to a little bit more about the midgut malrotation, I hope you know the normal rotation where the duodenum comes like that, like a C, and then so predominant, most of the proximal ileus, most of the proximal jejunum. Can you see my cursor on your screen?
Yes, sir, we can see.
You can see, yeah. So yeah, so duodenum will come down like a C, and then the bowel loops, the jejunal loops will be here, the ileum here, then the ascending colon and transverse colon like that. But in the malrotation, intestinal malrotation, you have the duodenum coming down like that, and then sometimes like a zigzag here, and then the proximal jejunal loops will be like a zigzag coming down on the right side. So the proximal jejunal loops in a contrast study will be on the right side of to the right of the spine, and then comes down like that, and then goes up, and then ileocecal junction would be to the left or on the midline, and then going like that. And this is not an isolated band here. This is the peritoneal reflection of the, so normally you have this peritoneal reflection in the paracolic gutter. So the same peritoneum is now going there. You see, now this would have been otherwise here, no? So that would be the normal peritoneal reflection of the parietal peritoneal wall going over the cecum, which is a retroperitoneal structure, ascending colon and cecum. So that peritoneum is lying here. So it's not an isolated band like that. It's this continues that way, this way. But so these, the peritoneal reflections, you can call them Ladd's bands. That's the surgeon who described it, William Ladd. So he described it first. So it's important to release them when you do a midgut malrotation procedure. It's called the Ladd's procedure. So you divide these bands, which will cause tethering and compression of the duodenum, even without volvulus. But now here, a volvulus has taken place. So the bowel has got twisted, so like a spiral here, and that will occlude the vessels and the gut, so that all this will undergo gangrene if you don't operate immediately. So midgut malrotation with volvulus is an emergency that you will have to do at whatever time of the day as soon as possible. So if it's in a hospital, it has to be done in the next available operating session. So you cancel everything else. So whoever who comes out of anesthesia in that hospital, in that theater, if there is free theater, there is no issue, has to be vacant for this thing, because otherwise this will kill, and it's even worse than killing. Sometimes if that patient survives, he'll have an agonizing death because of that. Then the only viable bowel will be a little bit of the duodenum, and then the cecum and the colon. So that's not compatible with life, but that will not cause immediate death also. So it will be a really, really agonizing death for the child, and agonizing time for the parents and the ones who are caring for that child. Okay, so if you take an X-ray in that patient, you will see a distended stomach, and you will see what is called paucity of air. So if there is a volvulus, if there is no volvulus, then they will have normal distribution of gas that you will not see whether there's malrotation or not on a plain X-ray. But if there is a volvulus, all that gases in that valve segment will be absorbed, and then so that will disappear, or just a few specks here and there. So it's called paucity of air. So if you see that X-ray, you don't even have to do a upper GI contrast study, but this is diagnostic of a midgut malrotation with a volvulus, and that child needs to be in the theater undergoing laparotomy as soon as you see this X-ray. And so if you don't have that, then you need to do upper GI contrast study. So you put a NG tube. All these bilious vomiting children needs to have an NG tube and to resuscitate. We have not now forgotten that part here. So all these children immediately needs a NG tube in if there is bilious vomiting. Put it on free drainage to prevent further vomiting and aspiration. You can even do what you call a gastric lavage with some normal saline, and then you do upper GI contrast study. So it will come like that, and then so the duodenum comes down like that, and then there will be hold up of, you don't see any contrast going beyond the second part. And so that's this is not the third part, this is just the second part, because of the volvulus. Can you see it's like a string which is like a twisted corkscrew. So that's because of the volvulus, it's gone that way, but it's completely occluded. So this child also has a midgut malrotation volvulus. And the operation is the lax procedure where you divide those lax bands and widen the mesentery so that there won't be a future volvulus. And also you do appendicectomy because the appendix is in such an awkward position that it will be impossible to make a clinical diagnosis of appendicitis because the appendix is in the now closer to the epigastrium or left hypochondrium. So clinically, it's impossible to make a diagnosis of a clinical diagnosis of appendicitis, and you will need to do a laparotomy or whatever. I don't know. Probably, yeah, these children will die otherwise. If you have appendicitis, it will rupture, perforate because it's impossible to diagnose it. So we do a prophylactic appendicectomy in them also. So that's the part of the operation. So then the next common cause of biliary vomiting is the duodenal atresia. Again, so this is the classic double bubble appearance. So you have the distended stomach and the distended first part of the duodenum. So this is a supine film, not an erect film. So you can see nicely the stomach distribution and the duodenum nicely with the pyloric narrowing normally. So that's the supine view AP abdomen of a patient with duodenal atresia. So this is, of course, the erect film somebody has taken, not actually one of our films. So here you can see the gastric bubble and the duodenum distended, grossly distended duodenum here. So you wouldn't see this in a midgut malrotation because this, that's a, volvulus that if that's in this massive dilatation is because it's been there for so long that the obstruction has been there intrauterine life. So it's a So duodenal atresia, the treatment is a diamond duodenostomy. So that's surgical procedure where you make you connect the first part of the duodenum to the third part of the duodenum surgically, and and usually have a fairly very good prognosis. Yeah. Because they do not have usually associated anomalies, except of course Down syndrome. So Down syndrome has a very high incidence of duodenal atresia, and sometimes they have associated rectal anomalies also, anorectal malformation. So if there is no Down syndrome or trisomy 21, then the prognosis is very good. Even otherwise, prognosis is, as far as duodenal atresia is concerned, it's good, whatever the rest of the problems are, but because you can't treat Down syndrome by doing a diamond duodenostomy, so you will have the problems of that. But duodenal atresia per se is now eminently treatable, and there should be very little morbidity and mortality associated with it. That's Meconium ileus. So that's another condition that causes intestinal obstruction, but it is commoner in countries where there is cystic fibrosis commonly. So this is the classical appearance of that Meconium ileus thing. This is not one of our films also. So, taken it from the internet. So that's again another classic appearance of Meconium ileus. And then, so this is treated by giving, so if you have gastrographin, which is a contrast material that if you can put it into the gut, enema as an enema, then it can wash off the meconium that is inspissated in the gut, very tenacious, thick meconium blocking the terminal ileum is the cause for it. There is continuity of the gut. So there is no anatomical or, there is no anatomical obstruction of the gut, but the meconium is so tenacious and thick because of the lack of pancreatic enzymes that it blocks the distal ileum. So if you can somehow wash it without doing a laparotomy, that would be the best. So that can be sometimes achieved by using gastrographin or mucomist enemas. But if it doesn't work, then you have to do an open laparotomy, enterotomy, remove all the meconium, and sometimes do a temporary stoma and then come out, or you can close the stoma and continue with that also. But majority of people would like to have a stoma and then close it. Okay. It's rare in our children, But so you have the duodenal atresia and then the jejunal atresia. So this is the proximal deflexure, then the jejunum, and then after a few loops, you have a atretic segment. So the atresia can be just a membrane across it, or a segment of gut also can be missing. So there are 4 types of atresia that you don't need to know. And so this dilated part is immediately proximal to the atresia, which is, so these narrow collapsed bowel is distal to the atresia. So this is the picture that you would see in proximal jejunal atresia. You see the stomach, duodenum, and a few loops. So you can, sometimes people call it triple bubble, or you can see just few dilated loops of bubble and nothing beyond it. So that's a classic diagnostic, pathognomonic, you can say X-ray, or classical X-ray of a proximal jejunal atresia. Once you see this, you don't need to do any further imaging. So this is diagnostic, and then you proceed with the laparotomy after resuscitating the baby. Okay, so then again, a little bit more distal bowel atresia. So you see a lot of large, several loops of bowel. So it's probably, you can call it more distal jejunal or ileal atresia. And in those patients, if you do a lower GI contrast, then you would see this microcolon. Can you see? It's like a string, very narrow bowel. And so that's usually associated with it, because this bowel is almost like a disuse atrophy, because Meconium has never entered this. So this confirms the diagnosis of ileal atresia. Okay, so those are the common causes of this thing. Hirschsprung's is a completely different entity. So Hirschsprung's disease also, when it is very severe, can cause present as a neonatal obstruction, but that would be usually it's a few days later, or sometimes even after the neonatal period, that you see these patients with Hirschsprung's. But again, you will see a lot of dilated bowel loops, and that's, Hirschsprung's is a completely different entity that you need a special, you need to talk about it at length if you want to. So any questions on any of these conditions, atresia, even Hirschsprung's, or any of these conditions that they discussed?
Sanjay, if you get a patient with radiological evidence of midgut malrotation,
yes,
without clinical evidence of obstruction, when you
alveolus, just
a chance finding.
Yes. Yes.
Yeah, without a volvulus, there is no evidence of obstruction. Do you have to do anything, or you just observe?
No, that's no. We always recommend doing a LADS procedure before, because volvulus is very common. I think say unlike those other conditions where you can, like a PPV or some of these, the other conditions that the patient might just live through without having any problem. Midgut malrotation is one thing that nobody would diagnose malrotation and observe it. Yeah, it's like sitting on a volcano. You never know when they will undergo, because it's such a drastic. I don't know whether there are studies of people observing them and finding out, okay, how many end up having this thing, but nobody is brave enough to do that kind of study because it's such a catastrophic event. So it's like, all these dog bites, we do not wait till rabies, features of rabies. We prophylactically, give the serum and everything, unless there is concrete evidence that the dog is immunized and all that. So it's a bit like that, because rabies is such a deadly disease. So it's a little similar. So you do not observe them as it is. I have never seen any study as to how many of them would have survived without volvulus, would have lived a normal life. And then, so I suppose if, a good study for a post-mortem, if you do post-mortems and, how many incidents of post-mortem, due to other deaths, that would be a good one for the JMOs to do, actually, because it's a very easy diagnosis, It's not a, I'm sure there may be some studies on that also, but no, I don't think in the, if you diagnose it at any point, that
I also didn't find that in the literature, because recently I come across an adult patient with malrotation, and that patient had X-rays which were taken childhood, and those were they were very classic about midgut malrotation.
Like upper GI contrast study, or
No, plain X-ray, but all small bowel on this side.
Right. And so this, so probably I think nobody really noticed it. I think if it went to a pediatric surgeon, that would be unlikely to be observed. I never seen anything like that, but it's an interesting one. I think I must do a little bit of a literature survey and see like postmortem studies. So, but only thing is now, how, like, have you seen doing adult laparotomies? Now, say you would have done hundreds of, maybe thousands of laparotomies now, midgut malrotation. Incidentally, have you found in adult who has otherwise been normal?
In my practice, I have seen only 2 adult malrotations.
Malrotations who have been otherwise normal, never had vomiting even, no? Bilious vomiting?
No. These 2 patients, both patients presented with obstruction.
Oh, right. So,
yeah.
Volvulus. No, but no, for say other scenes, like rectal cancer and then found to. No. Yeah. So they will eventually, I think, until, so very few now, say if normally these have an incidence of about 1 in 3,000 to 5,000 of midgut malrotation. So that, I mean, that would be a common occurrence then in, not a common occurrence, but if you do, yeah, but the postmortem, say if all these postmortem studies should reveal the incidence, I would say, undiagnosed ones. But certainly, if you see it, yeah, you have to act on it. Yeah.
Sanjay, sir.
Yeah.
Yeah, another question. This labs procedure, you said that an appendicectomy is performed to avoid future confusions and fatalities. But for the students who are listening, I think this is not the appendicectomy they see in a routine manner,
right,
isn't it?
Slightly different. It's called a Bishop-Koop appendicectomy. So we do an inversion. So, these operations are, now midgut malrotation operation is a clean operation where you do not enter into a hollow viscera like the bowel lumen. We don't open into the bowel lumen in that one. So we don't want to make it a clean contaminant. So appendicectomy, if you do it in the classical way, the bowel lumen is entered into. So we do not like to do that because that will add to the slightly increase in infection rates and things like that. So because of that, we skeletonize the appendix, then invert it, and then tie the base so that the appendix sloughs off and then falls off through the rectum, in a couple of weeks. So yeah, it's done differently. Yes. So not, so it's for interest sake. Yes. So that's a different appendix. It's called inversion. Bishop-Koop is the surgeons who describe it first. And then, so it's an inversion appendicectomy. Yes.
Okay, sir.
Anything else? All these conditions have an incidence of between 1 in 3,000 to 1 in 5,000 live births, and except the Meconium ileus, which is rarer in the Asian countries and more common in the Western world or Europe.
I think we can move on, sir.
Yeah, so we can either move on to the other acute surgical emergencies. Maybe we'll get into a little bit of the acute scrotum also, because that's an important topic. So acute scrotum is the acute painful swelling of the scrotum. So the most important thing that you have to remember is testicular torsion. But acute epidermolysis is also fairly common, either bacterial or viral, like in mumps or Coxsackie. And then the torsion of appendages also are quite common. So the rest of the things like idiopathic scrotal edema, which is the scrotum is swollen but not painful. So that's the difference between the other 3 conditions and this one. Scrotum is really swollen. These children, it's very frighteningly swollen, but the child is otherwise comfortable. And when you feel the testicle, it's difficult to feel through the swollen scrotum, but at the base of the scrotum, it's not so swollen, right at the place where the scrotum is connected to the trunk or the perineum. You can usually feel the testicle and usually painless and not swollen. So that's how you differentiate. Testicular appendage pain is not very severe. And also the tenderness is mostly on the upper pole of the testicle. The normal testicle itself is not painful. If the child is cooperative, you should be able to demonstrate that. The most important thing that you have to remember is testicular torsion. And the most important fact, if you just remember that fact, that would be enough. So any painful scrotum, it would be foolish to reassure the patient and send them if you are not 100% sure that it is not a testicular torsion. So the best thing for a primary care, like a GP or even a pediatrician, is to refer them to a surgeon to make sure that it is not a torsion. So usually if a really acute scrotum presents you within 12 hours or maybe within 10 hours, majority of the surgeons would recommend that you explore the scrotum. But if you can do an ultrasound without any delay, like within an hour, half an hour, if you can get a reliable ultrasound scan and with a color Doppler signal, then you can also do that, and then that might help you to differentiate the torsion from epididymitis. Nowadays, mostly we do that. But if in the periphery and if you are left without an ultrasound scan in the middle of the night, it would be always safer to explore the torsion, explore the acute scrotum, confirm that it is not torsion or not torsion, and then act accordingly. So that is especially if the patient presents to you within the first 12 hours or even 18 hours. But if it comes a bit later, say 24 hours, sometimes 2 days, then there is a little bit, I don't think if it is torsion, you're not going to save it anyway. So you can confirm your findings before, because some of them may be epididymocarditis also. So you can avoid unnecessary exploration by doing a color Doppler ultrasound, but some of them are not very reliable. So you have to be very, working in tandem with the reliable radiologists, because these are very operator dependent things. So if somebody is very familiar with doing these scans, we have that advantage of the radiologist at Children's Hospital, LRH. So they are very familiar with doing acute scrotum ultrasound. So we found very good concordance with their findings, but sometimes it can be a bit of a problem. So the best course of action is to do a exploration if the patient comes to you within 12 hours, and if you can't really identify any of these other conditions, to explore the scrotum. I don't think there will be any blame on anybody for exploring epididymocarditis and confirm finding epididymocarditis and not a torsion, because then you can even then the pain will be much less if you wash the testicles, then continue the antibiotics than doing otherwise. So the most important thing is the surgical opinion is mandatory before you give antibiotics. So we see it very often, more than malrotations and things like that. Acute scrotum sometimes is not properly managed in Sri Lankan general practice. So people give antibiotics and then they come to us either minus testes or in that very late stage, they are atrophied and gone completely, or they come with the gangrenous testes because people think antibiotics, and then, so you can't watch that. And these patients will be quite aware of it. So they might come back and litigate or, sue you. So it's important to remember acute scrotum is not the thing that can be managed by the inexperience. So it's always better, it's a rare problem now, it will be very minority of your patients. So get a surgical opinion before you do anything. So you don't need to know a great deal apart from that, but you can, the etiology, the different, we do not even try to say, okay, now testicle is in a high position, lack of cremasteric reflex, all that will only confuse you. You try to demonstrate them and you become more confused. So I don't think so acute painful scrotum needs to be assessed by a properly, experienced clinician, I would say. So that would be more a surgeon, because the pediatricians rarely feel these testicles and things, so they are quite clueless about it as well. So best for it to be referred to a surgeon or a pediatric surgeon, general or pediatric for that matter. So they will be able to act accordingly. So especially if they come within the first 12 to 24 hours, because once it goes beyond that, a real torsion, you have very little chance of salvaging it. But of course, some of these torsions, if it is not a twist, 2 or 3 twists will really make it gangrenous. So we have actually, I have found on 2 or 3 occasions, the one testicle is gone, but when we explore the other testicle to do a orchidopexy or fix the testes, then we have found that non-torted testis, which is normally now viable, but there is like a half a twist or 1 twist, but still, circulation is good, a little bit congested. So on 2 occasions, I have So nowadays I always at the same time you fix the opposite testicle. There is no place for doing it later or observing it, simply because of that reason. So these the anatomical problem is usually bilateral, especially if it is older. Neonatal torsions are slightly different etiology, but even those, because of the risk of torsion, majority of people fix it. But torsion in the adolescent or the toddler, you would always recommend fixing the opposite testicle, do what you call orchidopexy with a non-absorbable suture. So the most important thing to remember, do not treat these conservatively, and also get an experienced person to see it, the acute scrotum, which is not a common day occurrence. It's rare for a general practice to see it. And also, clinical differentiation of these conditions can be quite difficult. Okay, so remember those three. So that's the appearance of acute scrotum, and that's what you see. So that's the thing, and so this is the appendix of the testis, so that can undergo torsion. And can you see that's the scrotum? That this blue dot sign, in a fair child, especially like a Caucasian, you would see that through the unpigmented skin, the little gangrenous appendix, and in the ultrasound also, you would be able to sometimes see that with a small hydrocele, you can see the appendix of the testis swollen there. So if you have a good ultrasonographer with you, you can rely on that and act accordingly, and you can avoid unnecessary exploration. But yeah. Okay, any other questions? So I haven't really gone into details of the acute scrotum, individual signs of this and that. But if you have any queries, you can ask. Okay, shall I go on to the next one? So
Sanjay, did we talk about hypertrophic pyloric stenosis?
Yeah, so non-bilious vomiting, yes. So yeah. Sorry, yeah, non-bilious vomiting is so the common. I don't think I have the slides here. Yeah, so again, now, so that you would see in the neonate and infant and older children, non-bilious vomiting is quite a common thing. But in the neonate, especially the infant who is under 6 months, majority of the non-bilious vomiting is what you call physiological reflux. So people call it milk vomiting, kirivamane. And so that's a very ubiquitous problem. So much so that all these grandmothers, most of the parents are aware of it. So, and they don't really, think of it as an illness. So that's, the common knowledge among the population. So because of that, it's, and you don't need to treat it with any prokinetics, antacids or anything if it is harmless, just a little bit of vomiting. But around 3rd to 4th week of life, if there is copious amount of vomiting, and some people may say it's projectile vomiting also, and then associated with some upper, abdominal peristalsis, visible peristalsis, then you would always think that hypertrophic pyloric stenosis as the cause. And so the classic onset of symptoms would be in the 2nd or 3rd week of life, and then progressing and really worsening towards the end of the 1st month. And so they will always be non-bilious, and there won't be any bile at all in the vomiters. And so some mothers might, this projectile vomiting, sometimes even in a, with severe reflux, if the mother gives a massive feed, then the child vomits immediately after the feed, then they can also have a projectile. It's just the volume, I think, of the thing. But yeah, so, but the classic, the projectile vomiting is commonly due to pyloric stenosis. And so again, the most important thing in these patients is their resuscitation, because the treatment is fairly effective and straightforward. The pylorotomy is universal. There is no other operation other than pylorotomy for pyloric stenosis. And so the resuscitation or preoperative management of these children is the most, diagnosis, of course, is by what you call the most sensitive and specific diagnostic test is a test feed, where you would clinically feel the abdomen while the child is being fed. And so it's a little bit difficult and awkward when the child is being only breastfed, but if the child is already on some bottle feeds, it's much easier. But even when the child is being breastfed, you can feel it, because that's the best time to palpate the abdomen in a neonate, because the child will be completely relaxed. So if any other condition also, if you want to feel the abdomen quietly, you would, give something for the child to drink, particularly if the child is really thirsty and hungry, they will drink it. And these children with pyloric stenosis, sometimes if the stomach is full, you can't feel the pylorus easily. So we would put an NG tube, suck out everything, and give the mother, give the baby to the mother to be fed. And at the same time, you ask your assistant to aspirate the stomach also, go on aspirating it. And then you can easily feel the pylorus in the right hypochondrium near where you would normally have the gallbladder, where you feel for the gallbladder a little bit more medial. And you will feel it like an olive, or, like a Verodu Gediya, like olive. And that's the classic. So that in a, if an experienced examiner is doing it, that's the most sensitive and specific world over. The test feed is the ultimate diagnosis or the gold standard. But most of the time you don't, have the experienced examination. So then the ultrasound becomes the next best thing. So ultrasound also, if it is done by experienced radiographer, and if you measure the dimensions, like the muscle thickness more than 3 millimeters or length more than about 12 millimeters, then you can diagnose the pyloric stenosis fairly accurately. And then the resuscitation. Resuscitation is correcting the fluids and the electrolytes. The acid-base status will get automatically corrected when you correct the dehydration. So you put an NG tube, lavage the stomach, with some normal saline, and then start him on IV drip. Normal saline, nothing other than a normal saline. Rarely people use normal Ringer's lactate or Hartmann's, but we don't use the Ringer's lactate because that has very little potassium in it. So they are really hypokalemic, hyponatremic, and hypochloremic. So normal saline, usually at about, now normally these children are under 10 kg. So you are giving normal maintenance is 4 ml per kg. So you give a bolus and try to correct the initial dehydration, and then follow it up with a normal saline infusion, which is about 6 ml per kg. That's about 1.5 times. Sometimes you might even have to make it 8 ml per kg if he's really dehydrated per hour. So, if the child is 5 kg, you give 20, so 5 into 6 ml, so 30 ml per hour. Or if child is about 5 kg and really dehydrated, you can give almost 8 ml per kilogram per hour. So that will be 40 ml per hour. And then you add potassium also, KCl, about for every 100 ml you give, you add about 2 to 3 milliequivalents of potassium also into the fluid. So usually we make a 500 ml of normal saline bottle and put about 5 to 6 ml, or maybe even as much as 8 or 9 ml. So that will have about 15 to 20 millimoles in 500. So that will be a very concentrated one, that will have 40 ml of potassium in a liter. So only the Hartmann's will have only 5 milliequivalents or 5 millimoles per liter, whereas the fluid that we normally give has about 30 to 40 millimoles of potassium per liter of fluid to correct the hypokalemia, and then the chloride will also get corrected. And a good, sometimes when if the child comes to you, you suspect pyloric stenosis, and if you do a electrolyte before resuscitation, their potassium will be low, sodium will be low, and chloride also will be less than 100 if it's truly due to, you can almost differentiate by an electrolyte whether the child is just a gastroesophageal reflux or pyloric stenosis by looking at the electrolyte profile in a non-resuscitated child. So that's as sensitive, quite a sensitive one also. So sometimes when they, transfer, so before transfer, pediatrician tells us that the sodium is 145, chloride is 105, and potassium is normal, high normal, then you begin to think, it's probably not a pyloric stenosis. So it's quite sensitive in that way. but so your resuscitation is also complete on the resuscitation. So they have to be, sodium has to be rising closer to 135, and then the serum chloride level is a good indicator of the amount of resuscitation, whether the resuscitation is adequate. So we would want it to be nearing 100. Even if it is over 95, you are happy, but if it is closer to 100, you are happier that the fluid you have given is adequate and now the child can go to the theater safely. Because if you operate on a child who is hypokalemic, hypochloremic, acidotic, alkalotic, then the chance of mortality is higher than, because the operation itself is a straightforward operation and that can wait until the child is fully resuscitated. So it's not an emergency to do an operation or correct it surgically, but the pre-op resuscitation is absolutely important. Otherwise, you will end up with a dead child. Okay, so that's pyloric stenosis. Post-op recovery is usually very brisk. So generally, most surgeons would start feeds almost as soon as the child wakes up and then gradually increase. The child might vomit once or twice. That does not indicate that the surgical correction is incomplete, but if it goes on continuously, then that's an indication that the incomplete surgery. And rarely, if you are inexperienced, you can perforate the duodenal fornix, during pylorotomy. So one has to be careful, but that's for the surgeons to be careful. So what you need to know is the diagnosis and the pre-op preparation, actually, more important than anything else. That's what really matters. Of course, that can be done either open or laparoscopic assisted or laparoscopically also, but because the open surgery is also, if you do a circumumbilical incision, it's a bit like your pyloromat, laparoscopy thing. It can be done much quicker and also without any other instrument port. So it's more or less the same. So, it's just a matter of choice for the operator and the parent also. So that's it. Probably the recurrence is slightly higher, I think, among in the laparoscopic group, but I suppose it all depends on the experience, because these are not very common conditions now, particularly nowadays. You have so many pediatric surgeons all over the country, so individual unit has few patients. So because of that, difficult for somebody to become very experienced in a particular system. But yeah, it's a pretty straightforward operation. Any questions about pylorotomy or non-bilious vomiting? So pyloric atresia is also, where there is a complete cutoff of the pylorus with a membrane or a little gap. They also will have non-bilious vomiting, but at birth, straight away from the first day of life, they'll be vomiting by milk. So that's a very rare condition. Even as a pediatric surgeon, I have seen probably one or maybe two, I think so. Not really even worth remembering. So that also will cause non-bilious vomiting. And of course, about 10% of biliary, the duodenal atresias also will have non-bilious vomiting, because the duodenal membrane is above the pyloric. So about 60% of the atresias are distal to the bile duct, so they will have bilious vomiting. About 20% have proximal to it. About another 10-15% will have the accessory pancreatic duct distally, and so they will have on both sides. So a few of the duodenal atresias also can have non-bilious vomiting. Okay, that's an important thing to remember. Probably, that will be commoner than any other pyloric atresia and things like
that. Sanjay, shall we talk about tracheoesophageal fistula stuff?
Yes.
Because they may get a few MCQs.
Yes. So yeah, I can get a slideshow, but yeah, so tracheoesophageal fistula is like atresia of the upper esophagus. Usually the atresia is about 10 centimeters from the nose. So if an NG tube is passed, and there will be if you should be able to pass it about 10 centimeters, and then suddenly there is occlusion. So that is incomplete separation of that the trachea and the esophagus in its development, and common types of atresia, the tracheoesophageal fistula with or without, esophageal atresia. So we call it esophageal atresia with or without fistula, because about 10% or less than 10% slightly will have no fistula. Okay, so there can be pure atresia, but majority of the patients will have a fistula to the esophagus, the trachea. Okay, and also there is a entity called H fistulas where the esophagus is not atretic. Esophagus continues down normally, but there is a fistula connecting the trachea to the esophagus. A connection between the carina, just above the carina, there is a connection with the trachea, and then the fistula connects to the esophagus, but there is normal continuity of the esophagus. So they will not be presenting at birth. Usually they will present later on in life, either with recurrent aspiration pneumonias or sometimes abdominal distension, because they swallow a lot of air that is coming from the trachea. So that's a rarity. About 5% of the tracheoesophageal fistulas are these H-type ones. But the classic variety is what you call the type C esophageal atresia with fistula. That is, the proximal esophagus is blind ending. Okay, so the proximal esophagus is blind ending, usually ends at about the cervicothoracic junction or just below that. And the lower pouch is connected to the carina. Okay. And so the lower pouch is connected to the carina. So about 75% of the esophageal atresia with fistula are this C type, or upper pouch blind ending, lower pouch fistula. The lower pouch is connected to the near the carina, to the trachea. Very rarely to the right bronchus also, but that's extremely rare. And then there are other types where there is what you call a pure atresia. There is no fistula. So the upper pouch ending blindly, lower pouch also is ending blindly. And that is only about, again, another 7-8% of the tracheoesophageal or esophageal atresias are pure atresias, because there is no fistula in the upper tract or the lower tract. So that is fortunately, that is rare, because that is a little difficult to treat, because the gap, the gap between the upper pouch and the lower pouch can be quite a lot. So if it is more than about 3 centimeters, primary anastomosis can be a little difficult. Up to about 5 centimeters, it's possible, but sometimes they end up with strictures and other problems. So sometimes you end up doing a cervical esophagostomy and a feeding gastrostomy, and do later on reconstruct the gap, with either colonic conduit or gastric gastric pull-up, like after esophagectomy. Okay, so that's fortunately rare. The common varieties are the commonest is the upper pouch is blind ending, lower pouch connected to the carina, like a fistula. That's commonest. The next commonest would be the upper pouch. There is some of them can have a upper pouch also can be connected to the trachea with a what you call upper pouch fistula and a lower pouch fistula. Then you have the pure atresias. Then you have the H fistulas. Okay. Very, very rarely do you have that lower pouch is blind ending and the upper pouch is connected to the trachea also. Rare variety. Okay, so the common one is the upper pouch blind ending, lower pouch fistulating into the trachea. So if they ask that in the MCQ, so that's correct, type C. H fistula is also, not common, but it's out of the 4 other varieties, that is the commonest. And of course, that is difficult to diagnose because of this thing. So, but there is no atresia in that H fistula, only a connection between the trachea and the esophagus that has to be surgically corrected, of course, to prevent further aspiration. And so the most important fact about the esophageal atresia is if the antenatal or the ultrasonographers who do the fetal anomaly scans, either the obstetricians or the radiologists, if they can diagnose tracheoesophageal fistula, that would help in the eventual management, because now even recently, say last week, we had a child transferred from Ragama. Was it Ragama or Gampa, that who has been fed, he's given breastfeeds initially, because the diagnosis was done after the child started reflux, regurgitating and aspirating. So if you can avoid that, if you can avoid breastfeeding before, so that the antenatal diagnosis would be of great help. One thing, you can see this dilated upper pouch with a small gastric bubble, or you can see polyhydramnios. Always you see polyhydramnios in these babies with esophageal atresia. And so then you can avoid the aspiration. You can transfer these babies antenatally into a obstetric unit close to a pediatric surgical center, and then immediately refer them soon after birth. You can even warn the pediatric surgeon that this child is coming, so they'll be, maybe ready with the ICU bed and all that. So the antenatal diagnosis is going to help in the improvement of the overall survival. And then next is to diagnose them before you feed. So all children, I think it's a routine practice nowadays in the neonatal examination to pass the NG tube and make sure that the NG goes into the stomach before you feed the child. So that will help in different. So if the NG doesn't go in, and if it gets stuck at about 10 centimeters from the nose, and then to take X-ray, and if it is coiled in the upper esophagus, that is a telltale sign of a esophageal atresia. So that's the next way of diagnosing it. And of course, these children will be drooling saliva and frothing also. So that's another feature that you would observe in these children. So those children you should never feed. And once you diagnose the esophageal atresia, you should keep the child a little head up, because aspiration is not only saliva, but because the great majority, about 75 to 80% of children with esophageal atresia have a distal fistula. So the stomach is directly connected to the esophagus. So if ever there is intra-abdominal pressure, say if the examiner is very, keen on examining these children's abdomen, and if you put pressure on the stomach, you can easily squeeze the stomach and empty that content into the stomach. So it's much worse than saliva aspiration. So they will immediately get chemical pneumonitis, and that is even worse than aspirating saliva. So you try to keep them head up a little bit, about 20 degrees, and you avoid examination of the abdomen at all costs. Okay. And also there is a tube that is like a sump suction tube, that is double lumen tube with a suction on the inner tube called a replogal tube. It's like that pool sucker, same mechanism. There is a slightly bigger tube, and inside that there is a tinier tube. So it's like that Sengstaken tube with 2 lumens. So the inside tube, you apply suction. Outside tube prevents the collapse of the wall of the esophagus onto the inner tube. So that saliva is sucked. So the saliva gets pooled inside the bigger tube, and inside that bigger tube is a smaller tube with holes. So if you apply suction onto the inner tube, then you can suck out the secretions continuously. So low pressure suction on that inner tube will prevent saliva aspiration, and then you can transfer them to a pediatric surgical unit. And then next is, so generally we would try to do them as soon as possible to prevent further aspiration. And nowadays, if there is no other congenital anomaly, especially congenital heart disease is common among these patients. So if there is not a very bad congenital anomaly, I mean, like say persistent foramen wall, VSD, PDA, those are straightforward. So they will not have added mortality. But if they don't have a added, cardiac disease, so they will have, there is nowadays about mortality among this thing is about only 5%. So 95% of the, Waterston is the one who classified esophageal atresia depending on associated anomalies. So if they don't have associated anomaly, very good prognosis. So much so that, even, over the last about 4 years, in our unit, we haven't had a death from a esophageal fistula. We had even a child with esophageal atresia with Edwards syndrome, which is a very fatal condition. The Edwards syndrome, I mean, usual lifespan is about 1 year, but we managed to send them home after the sent from Kalutara, the child. So we been transferred the child back to Kalutara after the procedure. We don't know the long-term prognosis, but so tracheoesophageal fistula is a fairly straightforward operation nowadays. Very good. We have fairly good intensive care. Our anesthesia become much better than when we were registrars or the intensive care management is much better. So even if there is a problem with the anastomosis, we have TPN now. Not ideal, but we have fairly good TPN service. So because of that, the prognosis of a tracheoesophageal fistula is very good nowadays. Post-operatively, almost all of them have reflux. So because of them, they have to be put on anti-reflux medication, like domperidone, antacids, and sometimes you put them on Gaviscon. Although I don't know whether it's how effective it is, but anti-reflux medication is mandatory in all patients after tracheoesophageal fistula. Otherwise, they will get reflux, and reflux-induced strictures either in the anastomosis or lower esophagus. So I think that's what you need to know, I think. Huh?
Yeah.
I forgot that because I could have put some slides on. I think if I try to find some from the net, it will take a long time, I think. And so I hope it was enough. It's almost 11:15 now, 11:16. So maybe I don't think we have time for the surgical jaundice or this thing, although here.
Yeah, we will discuss surgical jaundice in some other day.
Some other days, so definitely too late, and most people must be now falling.
Thank you, Sanjay. Thank you very much. And students, these topics, especially the hypertrophic pyloric stenosis, bilious vomiting, and intersusception, torsion, right? And TOF, you get you won't get short cases or long cases, but definitely few MCQs and sometimes in the essay paper as well. So all the facts which we have discussed today, you won't get anything other than the facts which we have discussed today. Okay. I can assure you.
Hello, sir.
Thank you, Sanjay. Thank you very much.
You're welcome. Okay. Good night.
Good night.